my talk is on surveillance, and what we mean by surveillance is how do we take care of different cancer risk a patient with Lynch syndrome may have, and how do we keep an eye on these conditions, like these organs, before they even turn into cancer. So that's the idea of surveillance. So as Whitney already introduced, I run the high-risk GI cancer clinic, and I'm a gastroenterologist, and my primary role is I see these patients, but I do a lot of endoscopy on these patients. And if you remember from Katherine's talk, colon cancer risk is the highest. And that is core work for my Lynch cohort, I would say, is doing a lot of colonoscopy and trying to, find lesions at an early stage if you're going to find cancer, or removing polyps, which are precancerous, can be precancerous, and can turn into cancer. So that's the idea of doing a ton of colonoscopy. A lot of you in the patient cohort possibly have already gone through this. So they require intense surveillance from the endoscopy perspective, also sometimes upper endoscopy. So these things is the core work, what I do. Huntsman Cancer Institute has been really wonderful because they established this organ-specific clinic. And this is great for a community so that you can actually see an expert team on pretty much what risk you could have cancer for. So you may already know that we have different organ system kind of approach in this center, which is wonderful. So when I talk about cancer, I like to show pictures. The reason is we should know what it looked like as an endoscopy, as an endoscopist myself and as a patient. What could be Lynch cancer and how they can come up without really much warning. So these are two of my patients from this year with Lynch, and the first one is, I'm showing you a 55-year-old, I'm going to get my pointer out here just in case. So the first one is a colon cancer patient. He had a normal colonoscopy a few years ago. That time he did not know he had Lynch, but he did develop this big cancer within 3 years. And my other patient had ampullary cancer, which is basically cancer in the small portion of the small bowel where the pancreas and the bile duct drains, cancer of that area, and she had normal endoscopy 4 years ago. So saying that these the risk is still high, that if we don't get to do surveillance, we can still miss these cancers, and they can kind of creep up, come up anytime. So as Katherine already mentioned, whoever has Lynch syndrome, they have 50% risk of passing the gene. And this is based on those 4 or 5 genes I'm talking about here. What I usually kind of suggest the patients and families is when you are diagnosed, you are given this diagnosis with the gene attached to it. So it might be a good idea for you to know what gene mutation you're carrying. Is it MLH1 or is it PMS2? And that is just having more information known to you. This is in case when you go to a new place or when you're they're gathering data. And if you know that you have this mutation, I think it helps the provider in terms of kind of risk. And of course, getting more data eventually is helpful. But that is something you may want to still know, even though this looks complicated. So we already know colon and uterine cancer risk is the highest, but Lynch can touch many other organs: stomach, ovaries, hepatobiliary, urinary tract, which is your kidney, bladder, pancreas, small bowel, even brain. So a lot of organs can get involved with different risk patterns. Now, one thing we are doing at pretty much every institute, at least we should be doing, is we test all colon cancer for Lynch syndrome. So anyone gets diagnosed for colon cancer, any age gets tested for this. The reason is this is the one good way to find who has Lynch or who does not. Otherwise, as a gastroenterologist, if I see a patient for endoscopy, for colonoscopy, I may not find any polyps on a patient with Lynch syndrome, or I might find 5 polyps, or might find cancer, or maybe 10 polyps. So this is not a condition I can truly recognize just by doing a colonoscopy. So there are various ways to find this, the patients who have Lynch syndrome, but this is one thing to detect if they have Lynch syndrome using this technology where we can test all colon cancer. So when someone gets diagnosed with colon cancer, they should know that if it is a Lynch cancer or not. I think they should be told this, tested, this is not a Lynch syndrome. And if you're told that this is a Lynch syndrome cancer, you should receive genetic counseling. And that's the point here, that all colon cancer should be tested for Lynch syndrome. So why do we talk about Lynch syndrome? We're talking about it because this is not one of those orphan diseases or rare condition. This is actually a common condition. Prevalence, when we talk about, is anywhere 1 in 300 person to 1 in 400 person. That's pretty common. If you think about it, there are a lot of people who may be carrying a Lynch mutation and do not know. Also, when we think about colon cancer in general, 3% of all colon cancer comes from Lynch. So not a very big chunk, but still 3% is just from Lynch. So that we should kind of be aware of. And again, as I mentioned, it's not a polyposis, what we call lots of polyps when somebody gets a colonoscopy. Oh, I didn't have polyps. That doesn't mean you may not have Lynch. You can still have Lynch syndrome. So this is just one of those conditions. And we really suspect and detect based on family history and also personal history of cancer. And that's how we kind of find patients who have Lynch. We already talked about this. Catherine already mentioned colon cancer risk can be very high, highest up to 60%, but risk of any Lynch cancer in your lifetime could be up to 80%. So when we talk about surveillance, why are we doing surveillance? The idea is to prevent and to find things early on so that we can diagnose early and treat early. That's the whole point of any cancer surveillance. And Lynch needs more surveillance because the risk is so high. And how do we as provider, as team, decide how to surveil? So we have different bodies and societies with a bunch of experts who dig into a lot of literature, who does a lot of research. And then these bodies decide, okay, how do we decide how to do surveillance for this and that organ. So National Comprehensive Cancer Network is one of the bodies which is really followed by Cancer Center and is reviewed annually. So when I see patients in my clinic, I may be giving recommendations which are different every 2 or 3 years because things change sometimes. And that is based on all these society guidelines and new literature. But we have our own GI societies, AGA, ACG, and then there are other pancreas screening societies. So these are different bodies which actually come up with these guidelines to follow. Now, how do we surveil? So number one risk, colon cancer, colorectal cancer. So depending on what gene mutation a Lynch patient may have, MLH1, MSH2 has higher risk, so we start early with colonoscopy. And remember, these patients who have Lynch syndrome cannot get anything else to detect cancer. What I mean by that is you cannot do stool test. Really, that's not recommended because there is stool test to detect cancer in colon. That's not recommended in patients who may have Lynch. Colonoscopy is the only tool. So we start early by age 20 to 25, and for high risk, MLH1, MSH2, and MSH6, PMS2, we can do 30, 35. Now, 2 to 5 years prior to earlier cancer diagnosis, we can do that for patients who have had cancer before age 30. So family members of them can start early. So this is an intense surveillance, 1 to 2 years. And again, what I find on colonoscopy, I will decide future surveillance based on that. If I find polyps or not, that can drive my follow-up surveillance. This is an example. One unique thing I do in Lynch patient is I use a blue dye called CHROMOENDOSCOPY to look for these flat polyps. And polyps are these little bumps in the colon. And sometimes we can see them if they are quite visible, but sometimes they're flat and it's not. And I just want to give you this example because this is a polyp which is flat. And if I don't put arrows, you can barely appreciate the polyp. And this is hard in the endoscopy world itself. This is that kind of polyp. So I use the blue dye to help these polyps kind of pop up and the margins get clear. Not saying it's 100% needed, but this is a tool recommended by certain societies, and I think it helps sometimes at least to see flat polyps. So this is, if you have been a patient and had colonoscopy, you might have already known about this blue dye. So that's about colon, but there are other risks. So stomach and small bowel cancer risk is not as high, but we can do an upper endoscopy to look for that. We look for, again, various lesions, what we say, sometimes what we call precancerous or adenomas in stomach. We started a little later for one body NCCN, and then we can do it every 3 to 5 years, so not that frequent. We don't need it. And it's really based around your family history and your personal history and mutation. And this is really tailored around that. So it may not be same for every Lynch patient. And that's the point of surveillance, that it changes from one patient to other, even with the same mutation. The second highest risk is of endometrial or uterine cancer. This will be this talk, Dr. Maurer is here, so she's going to talk about it. But the main thing we talk about ovarian cancer risk and endometrial cancer risk is when can we remove these organs, or do we have to remove these organs, especially ovaries in one case. So those are the discussion I usually send a referral to my colleagues to talk about. But essentially the timing is the main discussion. Can we screen for them? That's another thing. Can we do endometrial, that is uterine biopsies or not? That's another discussion we do. So those are the things to consider in the world of how do we surveil uterine and ovarian cancer. One main thing to consider is, or from patient perspective, or for anyone to know, is watch for symptoms. That's huge. So any abnormal bleeding, any bloating, early satiety, etc., you're out of sorts from anything which is not resolving for a few weeks to months, then you must contact your provider. There's another screening for pancreas. If you have family history of pancreas cancer, this is not recommended for PMS2 mutation. This is another involved intense surveillance because you need MRI, which is going into this donut and getting screened. And another one is doing an upper endoscopy, which is just like an upper endoscopy, but it requires sedation, so more involved. And this needs to be done every other year. So one year MRI, the other year endoscopy. This is really recommended to be done at an expert center after we have informed like what it means to go through this surveillance and what's the pros and cons and things around it. So this is another thing we can do for patients of family history for pancreas cancer. And there's a bunch of other organ systems. So skin cancer, we do recommend surveillance every year. Breast and prostate, no known higher risk than general population we know of, so we don't do any special screening in this earlier or any of that sort. We just leave it as general population-based screening. Brain cancer, no special screening except we can do exam. And then urothelial, which is kidney, bladder, ureter kind of cancer, we can do a urine test if you have family history. So again, a bunch of screening based on what is the personal history, what's the family history, and based around it. So the most important thing from a patient, a person who could have Lynch or a family member, when you get this diagnosis, what should you do next? Now, once you get this diagnosis, I hope you've already met with a genetic counselor. That's the first step. Like you've met with a genetic counselor who has mapped your family history and figured out like who needs testing and what are the recommendations. And a lot of time they themselves will tell you this is what you need. You need a colonoscopy, you need an endoscopy, and things like that. Now, if you have an access to an expert clinic center like ours, I would highly recommend to approach that, because you don't have to, I say, kind of worry about your cancer as much, because you have a team of experts looking after this on a yearly basis, 1 to 2 year basis. And this is also very important when your family history changes, or when we have, I showed you those bodies, which makes a recommendation if their recommendation changes, which is sometimes quite frequent. All those things, someone has to know that. So these expert centers are really useful to keep track on diagnosis and follow-up. But if you don't have access to such an expert center, I would still recommend you contact your primary care provider, contact your gastroenterologist or oncologist or genetic counselor. If you have had someone you've seen, you might have already seen somebody for your colonoscopy, or definitely a genetic counselor. Especially if you have a new diagnosis of cancer in your family, or if you just want to know our recommendations changed. So those things, the best way is, if you don't have an expert center, go through your primary care physician or someone who's taking care of this. If the other side, when you want to talk to your primary care and a genetic counselor, is when your children are turning into adult, and if you have Lynch syndrome, you want to know if can they be tested. And these things are usually covered when you see genetic counselor, but those are the times when you should revisit your diagnosis of Lynch syndrome. Now, stay updated on your surveillance. You should remember that you need a colonoscopy every 1 to 2 years, more or less. That's kind of a most important surveillance. And then, like I said, for female organ surgery and those other things. But these, once you have a checklist of kind of keep an eye on those and then stay updated on your surveillance. Watch for symptoms, really important. So do not wait to seek care. If you have any symptoms and it's not resolving for a few weeks, don't wait for months. Just contact your primary care provider, contact us, or whoever is taking care of you. And the last point is talk to your related family members. And this also, you probably have already done once you've met the genetic counselor Lynch patient. But the reason is kind of to do a family discussion, like who needs testing, have they got testing, are they on getting a surveillance. So kind of doing a comprehensive family kind of care in case you think that somebody who needs testing has not been tested, who has been advised by your genetic counselor to be tested. So those things to kind of keep an eye once you get this diagnosis. And that's all I've got for today for the event. Thank you so much for listening.